In this unit, we'll be covering anti-infective agents. More specifically, we'll be looking at antibiotics, which are drugs that are used to treat bacterial infections. Due to time constraints, we won't be covering antiviral agents or antifungal agents, but I think you'll think this is plenty to kind of get your hands around. And because of that, I highly encourage you to use these drug charts. Use the drug charts that we have given you. Specifically, there's some. Well, let me rephrase that. There's some things on the drug charts that I would like you to add in addition to, or be sure you add this to the drug chart because it's not specifically mentioned in the charts themselves. So looking at the drug chart, drug class would be the class of antibiotics, penicillins, tetracyclines, cephalosporins, those kind of things. And then, the generic examples that we give you, so the ones that we cover in class. But the real broad part here, the piece that we need to expand in this chart, is the mechanism of action. And so I want you to know the specific mechanism of action for each of these antibiotic classes. Fortunately, the classes all have the same mechanisms. In addition, I would like you to know the spectrum of the antibiotic. In other words, is it broad spectrum, narrow spectrum? And we'll define that in a little bit here. Also, the activity, whether it actually kills the bacteria or just stops the multiplication and dividing of that bacteria. If it kills the bacteria, we call that cytal. If it just stops the multiplication, we call that static. And then the contraindications, if any, adverse reactions should be put in there. So the ones that we cover in class specifically, and then any drug or drug-food interactions that we have should be added to this as well under adverse effects or nursing considerations, wherever you want to put that. So be sure to make these charts, use them as a reference. I think you'll find it very helpful because these can all get kind of confusing and jumbled because they're all antibiotics, and it's a pretty broad class and heavily prescribed class of drugs that we use today. Just to briefly look at the history behind antibiotics, because they are, again, relatively recent in our armament for medicine, and I can't imagine how some of our ancestors practiced medicine before the discovery of these remarkable drugs. Obviously, at that point, they just would do supportive care, try to keep the patient alive until the immune system could essentially clear the bacteria from the body. But in the 1920s is really when it all kind of started, and Paul Ehrlich, who's pictured on the right side of the screen, was looking for a synthetic chemical that was effective only against bacteria and not against the human cells. In other words, so a selective toxicity is what he was looking for. He won the Nobel Prize in 1908 for his work in immunology, but he was looking for chemical agents that would help with the immune system itself. Sir Alexander Fleming discovered penicillin in a mold sample, and so he noticed that he had an agar plate that was contaminated by a mold spore just by luck or by chance, and he was observant enough to notice that around that mold spore the bacteria didn't grow, and so he knew there was something in the mold that was preventing the growth or killing the bacteria around it, and that was how he discovered penicillin. The next class of drugs in the 30s were actually the sulfonamides or sulfa drugs, which were at that time used in the dye industry, and so they were for colorization of things, and so the sulfa drugs were then discovered that it was discovered, I should say, that they inhibited bacterial growth as well, and so that was the next class of drugs discovered. As alluded to earlier, antibiotics can be considered, or I should say classified by the spectrum of bacteria that they are effective against. And so we call them either narrow spectrum or broad spectrum, depending on the numbers that number of organisms that they're effective against. So highly selective antibiotics are only effective against a few organisms. So for example, there's some now that are being synthesized and targeted at the gram-negative bacteria called Pseudomonas aeruginosus. And so Pseudomonas would be their target, and they're not very effective against most other bacteria. So those would be highly selective or very narrow spectrum antibiotics. Others that are considered narrow spectrum would be perhaps only effective against, for example, gram-positive anaerobes or just against gram-negative bacteria, and only a few of those. So, for example, gram-negative coliform bacteria or something like that. So again, they're very good at inhibiting a selective pathway or a metabolic pathway or some other mechanism that specific bacteria uses, but it doesn't work against bacteria that don't use that mechanism or that metabolic pathway or enzyme. Conversely, broad-spectrum antibiotics are very effective against a lot of different types of bacteria. So it may work against both gram-positive, gram-negative, maybe aerobes and anaerobes. And so again, they're very useful in treating a wide variety of infections, and oftentimes we'll prescribe a broad-spectrum antibiotic before we have our culture and sensitivity back to determine exactly which bacteria is causing the problem. And at that point, we can switch to a more narrow-spectrum antibiotic that'll will target that bacteria more specifically. So looking more at mechanisms of action, what Paul Ehrlich was looking for was a drug that was selectively toxic. And so what we're looking at is a drug that will selectively pick or affect a bacterial cell while leaving the human or mammalian cell unaffected, basically. So there are several mechanisms that we've taken advantage of because bacteria cells are different than us in many, many different ways. And so very commonly we'll see bacteria, or I should say antibiotics, that interfere with the synthesis of the bacterial cell wall. And so this is actually how the penicillin class works, and the next generation of penicillins, we call them cephalosporins. And so again, they inhibit cell wall synthesis. Thus, they kill the bacteria because they can't replicate and multiply, and they actually can't repair their cell wall either. And so now they become leaky, and the bacteria end up lysing. There's other drugs that prevent the organism from bacteria from essentially using their own metabolic pathways for their growth and development. And this is actually how sulfonamides work, and as we're going to learn later, that they inhibit the synthesis of the B vitamin folic acid, which is going to be necessary for their replication and multiplication. So again, a very common mechanism we see is affecting metabolic pathways. Finally, another common pathway is to interfere with protein synthesis. And again, proteins are used for structural integrity. They're used in metabolic pathways as enzymes. And so the very common class of antibiotics called tetracyclines use this as their mechanism of action to inhibit that. So this is, as you make your charts, this is one of the things you want to put on is what is the mechanism of action, bacterial cell wall inhibition, a metabolic pathway, inhibiting folic acid, protein synthesis, those kind of things. And we'll move on to a few more in the next slide here. Another common mechanism is interference with DNA synthesis. So this is actually how the fluoroquinolone group of antibiotics work. And without, again, DNA synthesis, without replicating DNA, you can't replicate the bacterial cell, and therefore it's a kind of a dead-end cell at that point. And then finally, some antibiotics, and this one is actually very common with antifungals, where they affect the permeability of the cell membrane. So essentially, they work much like the membrane attack complex of complement does, where they poke holes into the cells. And once they lose that osmotic integrity, they take on water and explode. And so the drug that I'll use as an example is amphotericin B. That's an antifungal agent. We will not be covering that in this particular unit, but that is how amphotericin works among other antifungals and antibiotics that are on the market. So after looking at mechanism of action, which again the mechanism is really why we have different spectrums of activity in the antibiotics, and here's another reason we have spectrums of activity. And some of it is that we have intrinsic or natural resistance to our antibiotics, whereas others are very sensitive to that particular drug. So if anti-infectives, if in other words, if the antibiotic works on a process in a microorganism or a bacteria, and that bacteria doesn't have that process, obviously that's going to be a natural resistance to that particular organism for that antibiotic. And so down here I've got an example where I've got salmonella, and then I have a couple bottles of penicillin by it. Well, salmonella is a gram-negative bacteria that doesn't have the enzyme that is necessary for cell wall synthesis that penicillin works on. And so it will not, penicillin is not effective against salmonella at all in the least little bit. And that's a natural resistance that salmonella has to penicillin. And so if a patient is infected with salmonella, you would be best off picking a different class of antibiotics, a different antibiotic that has efficacy against that gram-negative organism. The other type of resistance is what we call acquired resistance. And this is a huge problem right now today, particularly when we overuse antibiotics, and then essentially the bacteria evolve mechanisms by which that they become resistant, I should say, to an antibiotic. Typically when a new antibiotic comes on the market, it's highly effective. We have very little resistance, acquired resistance to that particular drug. Yet as we put selective pressure on these bacteria by exposing them to this new antibiotic, they develop techniques and mechanisms by which they can become resistant to that. And so, as it says here on the cartoon, if you want to be a superbug, let me stick a little bit of this into your genome, and all of a sudden now penicillin won't have an effect on you. And in fact, that's a very common mechanism that is used by bacteria, is to synthesize an enzyme. And that's how we call that a penicillinase enzyme. That's how many bacteria that once were susceptible to penicillin are now resistant to penicillin, because the enzyme destroys the penicillin drug itself. So let's take a look at some of the mechanisms that bacteria use to acquire resistance. All right, so the first mechanism that we'll look at, or first technique, or process, I should say, maybe, that these bacteria use is to really inhibit the ability for drug to concentrate at the site of action. And so there's several techniques that bacteria use for this. One is to just alter the cellular permeability to prevent the drug from entering into the cell. So if the drug has to get into the cell and bind to a certain enzyme or certain metabolic product, if we keep the drug outside the the cell, outside the bacterial cell, it's not going to be effective against what it has to, or against what it will do inside the cell. So it's very common also that we alter the transport system. So again, we're going to exclude the drug from active transport into, or increase the transport out of the cell. So the mechanism is basically to keep the drug out, or pump it out faster, or prevent it from coming in an active mechanism. Another possibility that drugs, another technique, I should say, that the bacteria use is to actually alter the drug target molecules. So they will actually change the binding site that the antibiotic used to bind to, giving it a different geometry, if you would, different structural integrity, and now that drug can no longer bind on that particular site. And so that's a real common one with the protein synthesis inhibiting antibiotics, where these bacteria will actually alter the binding site on the ribosome, or if it's a penicillin type drug where it's having an effect on the cell membrane, maybe it's going to alter the binding site on the membrane. And so even though the drug is there, now it can no longer be effective, because it can't interact with the process that it was intended to do. Another way that bacteria develop resistance is to antagonize the antibiotic that is being used. And so basically they're taking advantage of the principles that we learned about with competitive antagonism. And so they're going to, again, produce a chemical that neutralizes or antagonizes, I should say, the antibiotic. A classic example of that would be with sulfonamide drugs. Uh, Sulfa drugs, as we're going to learn, uh, inhibit paraaminobenzoic acid, or PABA, to be converted into folic acid. And uh, so basically, they're actually working as an antagonist in that particular. The sulfa drugs act as an antagonist in that particular mechanism, and so the bacteria just produce an increased amount of PABA, and that increased amount of PABA can overcome the antagonism that the sulfa drug is causing in the organism. And finally, they can produce enzymes that inactivate the drugs or metabolize the drugs. Classic example of that would be penicillinase, where the enzyme breaks the beta-lactam bond on the penicillin ring, and without that ring, the beta-lactam ring, penicillin isn't effective, and so that's a very common way that that penicillin resistance is developed, is to increase enzymatic cleavage of that ring. As we're going to learn, there's a lot of different classes of antibiotics, and they all have their pluses and minuses, their strengths and weaknesses. And so, how do we go about deciding which one to use? And so, number one is always identification of the correct pathogen. And typically, we do that with our culture and sensitivity, which we'll cover in a second. I believe that you should have covered that in your microbiology class, but we want to remember we said that there's a spectrum for antibiotics, and they cover certain ones very well and others not so well. And so we want to identify that pathogen, and even more importantly, test to see which antibiotic is the best one to use on that pathogen. But at least if we know what the pathogen is going to be, we have a pretty good starting point to decide which antibiotic to start using. The next one is, we're gonna select the drug based on that pathogen, and again, there's going to be multiple different drugs that we can decide to use for that particular pathogen. And so now we need to start looking at patient factors and saying, hey, which one causes the least amount of problems for the patient and would have the best benefit for that. And so again, may not, typically you'd say it's the one that's most effective against the pathogen, but maybe, like we're going to learn, aminoglycosides cause kidney toxicity, and so if you've got a kidney patient, you may not want to pick that particular drug, even though it would be highly effective against that bacteria. And finally, we'll look at host factors. So, where's the infection? So, can the antibiotic get into the site? Obviously, it has to be there to have activity, and so it has to distribute into that area in concentrations that would be effective as an antibiotic. Are patients allergic to it? Obviously, if they're allergic to it, you wouldn't want to use that particular one. And we already talked a little bit about toxicity. So, for example, if you've got a patient that has renal failure, you may want to stay away from certain classes of antibiotics that cause renal toxicity, like our aminoglycoside antibiotics. So as we said in the previous slide, we want to find out which pathogen it is, so identify the pathogen by species, and gram-positive, negative at a minimum, and preferably by species. And then we want to find out which antibiotics are effective, and so because that'll help us decide what to prescribe or treat that patient with. And so if we look at this antibiotic sensitivity test in the picture on the right hand side, we've already identified this pathogen. We know what it is, and every one of those discs have been impregnated with an antibiotic that should be effective against this particular strain, or at least this particular organism, bacterial organism. And if you notice, there's a few that are fairly effective, but if we look at G and E and B, there's a pretty wide zone of inhibition. And so we'd say, hey, those are probably effective depending on the diffusion rate that they have. Where I look at A and C, and there's really no effect. So that strain of bacteria is totally resistant to that particular strain. So once we have, we know in the lab which one works, we'll go ahead and use an effective one in the patient, and that'll enable a much higher success rate in treatment of those patients. In fact, I've got an interesting story that I had when I was in veterinary practice. I had a client who had an outbreak of what we call calf scours, which is basically just calf diarrhea. Neonatal diarrhea is what it is. And we had done some culturing of the diarrhea and found out that it was actually a pathogenic E. coli that was causing the diarrhea in these calves. And then we did a sensitivity on that E. coli and came up with an appropriate antibiotic to use in them. About 3 or 4 days after we had done that, we got a call from, or actually I got a call from a physician, and he said, this woman was also, the woman, the rancher's wife actually, but had diarrhea, and he thought it might be related to the outbreak of calf scours that they were having on that ranch. And so he asked me if we had culture sensitivity results, and I said, "Oh, we absolutely do." And it was an E. coli, and I gave him the information of which antibiotics were effective in this particular case. And so he prescribed one of those antibiotics to the woman, and about 3 or 4 days later, he called me back and said, it's really nice. We just got our culture and sensitivity back, and it's the exact same strain with the exact same sensitivity and resistance pattern. And so she recovered very, very quickly, where otherwise he would have been guessing and trying to decide, well, give him a broad spectrum and hope things work for the best. So there's a case where, communicating between practitioners was very, very effective. Now that we have some of the background information on antibiotics, we're going to start looking at antibiotic therapy specifically. So the first place we'll start is kind of trying to define what it is. And antibiotics are simply chemicals or drugs that inhibit specific bacteria in specific ways. And so we'll kind of, from here on, start looking at specifics within the antibiotic world that we're studying at this point. When you start a therapy, you always have to have a goal for the patient. And so really the goal for antibiotic therapy is to aid the immune system. And we think of antibiotics as actually clearing the organism from the body, but that's not really true. It just is an aid to help the body deal with that invading microorganisms. So the immune system is very important on virtually all antibiotic therapy. And as alluded to earlier, we have two different definitions or types of broad categories, I guess I'll say, of antibiotics. And it's those that are bacteriostatic versus those that are bactericidal. And so bacteriostatic are ones that they just prevent the growth of the bacteria. They prevent the multiplication of the bacteria and rely on the immune system to clear the bacteria on its own. Bactericidal antibiotics, on the other hand, actually do kill the bacteria directly. And so again, if you've got some immune compromise, you'd want to select a bacteria that select an antibiotic that is bactericidal rather than bacteriostatic, because that is going to help the immune system much more, or help clear the organism much more, because we don't have to rely on the immune system as much as the bacteriostatic drugs do. So we classified antibiotics as bacteriostatic or bactericidal. We also are going to classify them based upon the susceptible organisms that they attack. And so your book really has a nice table, 83-3, that shows this classification. But so we're going to classify it as gram-positive. If you remember, those that have cell walls that retain the stain or resist the decolorization, if you would, during a gram stain. And so these guys they take up gram stains, so they're gram positive, so they look blue on the gram stain. Gram negative bacteria, on the other hand, lose the stain when you do the alcohol wash, and so they don't hold that, primarily because they have lipopolysaccharide in their cell wall. And again, they'll be red color on a gram stain rather than the blue color. We also classify them as aerobic versus anaerobic. So aerobic bacteria need oxygen to survive. Anaerobic typically don't. So they can live just happy lives without any oxygen in their world. So again, these are the four different ways that we're going to classify the bacteria that are susceptible to the antibiotic. And then finally, before we jump into individual classes of antibiotics, there's another way we classify them, is really by their mechanisms of action. And so if you look at your table 83-4 in your textbook, again, it's got a nice little classification of that by mechanism of action. So, and this is how we'll kind of follow this pattern, this outline in our lecture from here on in our walk through the antibiotic world. And so we'll look at inhibitors of cell wall synthesis. We'll look at the penicillins and cephalosporins. Then we have the cell wall disruptors, which we mentioned earlier. Amphotericin B was the one we talked about. And we're not going to, most of these are specific drugs or antifungal drugs, and so we're not going to cover these in this class, but just be aware that there is a classification of anti-infective agents that disrupt the cell wall, poke holes in the cells actually, so they can lyse the cells. A very common category is inhibitors of protein synthesis, and we'll look at there's different mechanisms by which these antibiotics inhibit protein synthesis. Some of them are going to be bactericidal. So going back to the first two categories, if the inhibitors of cell wall synthesis and cell wall disruptors are definitely bactericidal, right? They're going to kill the organism. Where protein synthesis, inhibition of protein synthesis, some of them can be bactericidal, or they could be bacteriostatic. So we'll look at the aminoglycosides and how do they actually kill bacteria versus our bacteriostatic inhibitors of protein synthesis like macrolides and the tetracycline classes of antibiotics. So we'll look at that as we move forward. Then we'll have the DNA RNA inhibitors, which we'll look at one class of those. Those are fluoroquinolone antibiotics. And then finally, we'll look at our antimetabolite antibiotics, which are the old sulfa drugs. And more specifically, most of the time we'll use sulfa drugs in combination with another antimetabolite called trimethoprim. So we will look at that as we move forward. The first category of antibiotics we'll look at is the penicillins, or are the penicillins. They were this is the oldest class of antibiotics that we have, and penicillin itself was the first antibiotic introduced for clinical use. They're known as beta-lactams, and if you look at the structure on the right, I've got the beta-lactam ring circled. And this ring is critical for the function of penicillin, or beta-lactam antibiotics, I should say. And so just to find what beta-lactams are, and again, I'm not going to ask you this on an exam because it's kind of a chemistry type question, but beta-lactams have a nitrogen, if you see the nitrogen there in the circle, and then they have what's called a carbonyl group, which is the carbon with the double bonded oxygen, and then it's got two more carbons. So if you look at this one, it looks like a square box essentially with three carbons and a nitrogen, and one of those carbons is a carbonyl group. And so because there's two carbon atoms in addition to the carbonyl group, it's called a beta-lactam. So it's beta is the second letter in the Greek alphabet, so the chemists call that a beta-lactam. So that's where the name came from. Penicillin itself is a narrow-spectrum antibiotic, and so it's virtually only effective against gram-positive bacteria. And it is effective against some aerobes and some anaerobes, but they're all gram-positive aerobe and anaerobe bacteria that it'll be effective against. Penicillin itself comes in two different forms. Penicillin G is the injectable form. There's a soluble form of penicillin G called potassium penicillin G that dissolves in water. And then so that one can be given either IV, IM, or sub-Q, just really any way you want to give it. And then there's a procaine penicillin G, which is given IM only. That's a suspension of penicillin. So you're actually injecting procaine penicillin crystals, if you would, into the muscle or under the skin. And that one is used because it takes a little longer to be absorbed. It lasts a little bit longer in the body because of that. And you have to give fewer injections, which can be relatively painful if they're IM injections. Excuse me. And then finally there's benzathine penicillin, which is the long-acting form of penicillin. And that one takes about 7 days to be absorbed through the system. So you can actually give that injection once a week, or maybe even only one dose is all they would need for that. Unfortunately, penicillin G is acid labile, meaning that it's destroyed in stomach acid, and so you can't take that orally. And so because of that, we have penicillin V, which is acid resistant, and so penicillin V will not be destroyed in the stomach acid. While penicillin itself is narrow spectrum, we do have some broad spectrum penicillins. So these have kind of been a second generation, if you would, penicillins. And those are the ones I want you to know are amoxicillin, ampicillin, ticarcillin, and methicillin. And so by broader spectrum, what we mean by that is they have activity against gram-positive bacteria like penicillin does, yet they also now have some activity against susceptible gram-negative bacteria. So that's why they're broad spectrum. So how does it work? Well, penicillins actually inhibit the synthesis of the cell wall in the bacteria. And it does that by inhibiting the formation of what we call the peptidoglycan crosslinks. So if you remember from microbiology, those are important crosslinks that we have in bacteria that give the integrity of that maintain the integrity of the cell wall. So how does it do that? Well, exactly the beta-lactam portion, that little ring that's in the red circle there, binds to an enzyme. The enzyme is called transpeptidase, and that transpeptidase is the enzyme that links the peptidoglycan molecules in the bacterial cell wall. And so without the ability to make that enzyme work and link the peptidoglycan molecules, the bacteria can't fix damaged cell walls, and the cell ends up being destroyed because the cell wall lyses, or the integrity of the cell wall is compromised, and the cell itself, the bacterial cell, is lysed. So therefore, these antibiotics are all bactericidal. So the indication for penicillin use, or specifically beta-lactam use, penicillin beta-lactams, would be the treatment of infections caused by susceptible bacteria. And some common ones that we see are streptococcal infections, pneumococcal infections, staph infections, and I put on there kind of the other susceptible bacteria. So again, we could have some gram-negative ones in there as well, depending on which penicillin we decide to use. The pharmacokinetics of these is that they're all well absorbed from the GI tract with the exception of penicillin G, because remember penicillin G is destroyed by the stomach acid. And if we look at the pictures on the right hand side, we'll look at the injectable form of that. And so the Pro-Pen G is procaine penicillin. So that would be, if you notice, it's kind of, you can see there's, I don't know if you can see it very well, but it's a white colored suspension basically of procaine penicillin G crystals. And again, that you wouldn't want to put that in the vein. You'd have to put that in the muscle or subcutaneously. And then you have the bicillin long-acting. That would be our benzathine penicillin. And so if we look at the pharmacokinetic profile graph below that, we'll kind of see why we have differences. So if we look at, this would be an IM injection of the three different types of penicillin G, so there's potassium and sodium penicillin G, so the salts, right, the penicillin salts. There's procaine penicillin G, and then there's the benzathine penicillin G. And so the red line, notice how it peaks up very quickly within an hour. We have a very high concentration in the blood, but then it's diminished very quickly as well. It's almost gone by 2 hours. We're an IM injection, the procaine penicillin G, if you notice it peaks at about 4 to 5 hours in that range. Peaks at a much lower level than the salt did, and maintains pretty good concentrations out to the 12 to 18 hour range. The green line in the bottom would be the benzathine penicillin, where we have a very low concentration in the blood, but it stays very, very flat and steady for really out to about 5 to 10 days, depending on the dose in the individual. So that would be the long-acting penicillin G. Penicillin is excreted unchanged in the urine, and so, in fact, in physiology from me, I talk about how they actually extracted penicillin from the urine in patients during World War II when there was a penicillin shortage, because it's unchanged in the urine. However, that means that we need to be careful with patients that have renal disease, because we will not excrete the drug as quickly. Finally, the major adverse effects of penicillin are really immune reactions. And so there are a lot of people that are allergic to penicillin. We can have type 1 reactions, which can be as severe as anaphylaxis. So that would be our IgE mediated, with massive amounts of histamine being released by our mast cells. Or we can have type 3 serum sickness. So if you remember, that was the immune complex formation, where penicillin is the hapten, combines with a protein, and gets stuck basically in different parts of the body. So if you remember, there was actually a picture of an Arthus reaction when we dealt with our hypersensitivities, and that Arthus reaction was actually a penicillin allergy that was going on, a type 3 hypersensitivity. They call it serum sickness because it mimics the response that a lot of patients would have when they took anti-serum for other infectious diseases that was produced in animals. And so you'd have this delayed immune complex mediated type reaction with penicillin. The major form of acquired resistance in bacteria is the production of an enzyme that hydrolyzes the beta-lactam ring, or destroys that beta-lactam ring. So remember, that ring is critical because that's the part of the antibiotic that binds to that enzyme, that transpeptidase enzyme. And if that is destroyed, as we see in the upper equation, see that beta-lactam ring, beta-lactamase just basically oxidizes and destroys that ring. Also destroys its ability to bind to the transpeptidase and inhibit cell wall synthesis. So that is the major mechanism by which antibiotics use that. So the chemists have become kind of, I should say, bacteria are good at developing resistance, and so are we, basically. And so the chemists have come up with some penicillinase-resistant penicillins. You've probably heard of the first one, methicillin. You've heard of MRSA, is very commonly referred to. MRSA stands for methicillin-resistant Staph aureus. And so what that means is that Staph aureus has actually developed another mechanism to defeat methicillin, so our penicillinase-resistant penicillin, basically. There's also nafcillin and oxacillin, so there's several of those that are out there and used in penicillinase resistant, or penicillin resistant, I should say, bacteria. There's also a combo product that is used, and that combination is with clavulanic acid. And so if we look at clavulanic acid, I've got an equation down there in the bottom of the screen. Clavulanic acid is actually a beta-lactamase inhibitor. And so what we do in that case is we take the clavulanic acid and combine it with a penicillin, like for example ticarcillin or even amoxicillin. So augmentin, the one on the left-hand side of that screen, is actually amoxicillin plus clavulanic acid. So amoxicillin is not a beta-lactam or penicillinase resistant penicillin. And so we put clavulanic acid in there, and that basically competes with the penicillinase. So penicillinase is trying to attack that, allowing either the ticarcillin or the amoxicillin, depending on, there's timentin, which has the ticarcillin, augmentin on the left, the picture on the left, which has the amoxicillin. That one allows them to be active and prevents the penicillinase from cleaving the beta-lactam ring. The next category of antibiotics are also beta-lactam antibiotics. And so if we notice again, looking over at that structure, we have that beta-lactam ring that I've got circled in red. The difference being is we have a different ring connected to that and some different moieties on the, some branches that are coming off. So again, I don't expect you guys to be medicinal chemists and understand, or I should say, I won't test you on the structure of these items, but I just want you to realize that there's again a beta-lactam involved in this. So these are very similar to penicillin in structure and activity, but the reason that they are so popular is they're less susceptible to penicillinase. And as we're going to learn, they actually have kind of have different generations of effects. And so they're, again, very commonly prescribed in infectious diseases. So much like penicillin, they interfere with the cell wall synthesis because they just like penicillin, inhibit the transpeptidase enzyme. And so, again, they're bactericidal because they destroy that cell wall integrity. The indications for these are treatment of infections of susceptible bacteria, and I don't list those at this point because there's different generations that have many, many different susceptibility patterns. So we go from broad spectrum to very narrow spectrum and then back to broad spectrum again. So we'll look at those when we deal with the different generations of cephalosporins in a bit. These are most of them are well absorbed from the GI tract, although some of them are used intravenously and intramuscularly. Most are metabolized in the liver and excreted in the urine, like most other drugs. So cephalosporins are a little more complex than penicillins in that we have kind of these generations of cephalosporins, and your book has in table 85-1 has a nice table describing these generations, and so we're going to have the oldest would be the first, and then we'll move on. So as we subsequently move to different generations, different iterations of these generations, the higher the generation, actually the newer the drug is, basically that's been approved on the market and put on the market. So the oldest beta-lactams we call first generation beta-lactams. We call them moderate spectrum agents, so they're not broad, but they're not narrow spectrum, so they're kind of in between the two definitions. So we have slightly more gram-negative activity than we see with the penicillins, and yet we maintain that gram-positive selectivity that we see with penicillins as well. Some common ones, first generations that you'll see in practice are cephalexin, cefadroxil, and cefazolin, very, very commonly prescribed first generation cephalosporins. So as we move in generations, I'm going to maybe generally tell you how they work. So number one has an increasing first generations are increasing activity against gram-negative anaerobes specifically. Our second generation, we start getting better beta-lactamase resistance. Okay, so again, we're going to expand a little bit. We get a little bit more gram-negative bacteria, and we also have more beta-lactamase resistance. Some examples that you should know with these would be cefaclor, cefonicid, cefuroxime. So those are three on the list of second-generation cephalosporins. When we get into third generation in a second here, the third generation seem to enter the cerebral spinal fluid better, so they work better for brain infections than the first and second generation do. So let's look at those next. So our third generation cephalosporins, now we're actually starting to narrow the spectrum a little bit. And so we're looking at an increased activity in gram-negative bacteria. And most importantly, it has some Pseudomonas activity. But we start losing our activity against gram-positive. So third generation cephalosporins actually are targeted more at gram-negative bacteria and less active on gram-positive. So a few examples I want you to know is ceftriaxone, brand name Rocephin, and ceftazidime, which is actually a drug that targets Pseudomonas. And Pseudomonas aeruginosus is a bacteria that's a real problematic gram-negative bacteria. It's particularly the fourth generation cephalosporins. Now we go back the other way. We start extending the spectrum a little bit. And so we have similar activity against gram-positive to the first generations, which the third generation didn't have. Remember, we lost most of our gram-positive activity. So now we go back to having gram-positive activity. But really the hallmark is they're more beta-lactamase resistant. So if we have penicillinase-producing antibiotics, these are more effective. Bacteria. These antibiotics are more effective against them. And they also maintain their activity against Pseudomonas, like we had with our third generation, some of our third generation. So an example of that would be cefepime. Maxipime is the brand name. And finally, our fifth generation. These are actually a few targets. We have a few targets with the fifth generation, and one of the major targets was MRSA, the methicillin-resistant Staphylococcus aureus. And so this one has activity against that, and so is one of our antibiotics in the armament trying to attack MRSA. And it maintains gram-positive activity, and it also retains the activity of the later generations of cephalosporins, having the broad spectrum activity against gram-negative bacteria. And so the fifth generation, I want you to know, is ceftaroline teflurol. Teflurol is the brand name for that. So wrapping up the final commonly prescribed beta-lactam antibiotic are the carbapenems, or at least categories of beta-lactams would be carbapenems. These, just like the cephalosporins and the penicillins, inhibit cell wall synthesis, so the mechanism of action is really the same in all beta-lactams. This one is really a broad spectrum, which is why it's used very commonly. Is it gets most gram-positive and gram-negative, both aerobes and anaerobes. So again, it's used kind of in cases where you just kind of you're not really sure what they have, and we want to make sure that we cover all our bases. Unfortunately, none of them are active against the methicillin-resistant Staph aureus or MRSA. Like all beta-lactams, it's bactericidal. And the prototype that we'll cover in here that I want you to be aware of is imipenem. There are 4 carbapenems on the market right now. Imipenem is one, meropenem is another, ertapenem and dorapenem are others, the final 3. So we'll look at imipenem. This one is, since it's not absorbed from the GI tract, it's used as an injectable only. And it's metabolized in a weird place, so not the liver like you see with other drugs, but it's metabolized in the brush border enzymes of the proximal tubule in the kidney, so the proximal convoluted tubule in the kidney. It's combined with a product called cilastatin, or a drug called cilastatin, and that actually inhibits the brush border enzymes and allows a longer half-life, in other words, for the imipenem to work. And that combination product is known as the brand name Primaxin. The major adverse effect with this one is nausea and vomiting, so it's pretty well tolerated. The next category of drug that we'll look at, or antibiotics we'll look at, are glycopeptides, specifically vancomycin, brand name Vancomycin. Vancomycin has the same mechanism of action as beta-lactams, so it inhibits the cell wall synthesis, and it's also bactericidal, much like beta-lactams are, or most beta-lactams. But it's a narrow spectrum drug. In other words, it's only gram-positive organisms, and so both aerobes and anaerobes, but primarily gram-positive. This is an important drug. It's a very powerful drug because it's the drug of choice for methicillin-resistant Staph aureus and for Clostridium difficile, which causes a pseudomembranous colitis that can be life-threatening. In other words, an inflammation in the colon because of overgrowth of Clostridium difficile in the distal bowel, and other serious infections that are gram-positive sensitive organisms. The primary adverse effect is you'll see renal toxicity or renal failure, and this one's actually important enough that this drug and the next category that we're going to talk about, aminoglycosides, it's a category of drugs that we actually monitor blood concentrations. And so it's a very good, the standard of practice before we get the next dose of vancomycin would be to draw blood on the patient, send it to the lab, get a blood concentration when it's at the trough. In other words, when we assume it's going to be the lowest before the next dose, so right before you're going to give the next dose. And if the trough is above a threshold level, you're not going to want to dose that patient and may have to actually diminish the dose for the next time round. Another major side effect that we'll see is it's an irritating drug to the blood vessels. And so we need to dilute this drug. If you notice in the vial, I've got circled in there that says after reconstitution, it must be further diluted before use. So you can't just draw it out of the vial, and inject it directly into the IV catheter. It's got to be diluted into a larger volume, anywhere from 100 to 250 milliliters of fluid to run that. And it causes, that irritation causes an inflammatory response, which results in a thrombus, and we call that thrombophlebitis. So thrombophlebitis is a thrombus that's formed in the vein because of inflammation due to that irritation of the vancomycin. Primary drug-drug interactions are other nephrotoxic drugs. So we'll cover aminoglycosides next. Again, a nephrotoxic, powerful antibiotic. We'll see this with cyclosporine that we covered in the immune suppressors, and our non-steroidal anti-inflammatory drugs would all be interacting with vancomycin. Our next group of antibiotics are the aminoglycosides, and these are very powerful antibiotics, typically used in hospitals, patients that are in the hospital, and these are primarily going to look at focusing on gram-negative aerobic bacilli. And so again, Pseudomonas is a gram-negative aerobic bacilli. So these are typically used or can be used for pseudomonal infections in patients. Some common ones that are out there, gentamicin is the most common. That's the second one on the list. And then tobramycin, amikacin, those are injectable forms. And then we've got neomycin and streptomycin. Those are typically used topically in topical ointments. So those, again, would not be used in hospitalized patients, but they would be used in topical creams, although they are used in systemically in certain situations. So these drugs, even though they're, and we'll talk about a second, they inhibit protein synthesis, but these are bactericidal drugs that inhibit protein synthesis, which is kind of unique to them. And so the way they work is they inhibit protein synthesis. And so if we think about protein synthesis, you have translation, first of all. Transcription goes on. So you go to the DNA and you make your messenger RNA, so you transcribe the DNA. And then you go to translation, where you go up to the ribosomes. And the ribosomes are made up of two units, a large unit and a small unit, or they call it a 50S and a 30S. That's just based on the size of what they are. And that's where they start binding to the ribosome, and then we have our amino acids are brought in, and we start making our proteins. So that's protein synthesis, if you remember that from your intro bio class. And these drugs bind to the ribosome, and specifically they bind to the small 30S ribosomal subunit. And the way they work is they can, if they're there when protein synthesis starts, it'll block the initiation of the start of protein synthesis. Or if protein synthesis is going on when the drug arrives there, it'll actually terminate the synthesis before it's completed. And then finally, another thing it does, it causes misreading. So in other words, we get faulty proteins. So the wrong amino acids are put in sequence, and our tertiary structure is abnormal, and therefore the protein is faulty and doesn't have its normal function or functionality. Aminoglycosides are really poorly absorbed from the GI tract, and so that's why they're either given topically in ointments, or usually they're given IV. I mean that's the standard route that they're given, so intravenous, but they can be given IM. And since they're also used, interestingly enough, since they're not absorbed from the GI tract, you can use them to help kill the gram-negative aerobes that are in the gut before you do surgery. So sometimes you'll see them prescribed in that way, so that it's actually a local effect in the GI tract, not something that's absorbed in the bloodstream because of oral administration. They do actually distribute through the body very well. So they're widely distributed, and they do cross the placenta, and they do enter breast milk. Again, since they're not absorbed, it's really not a problem for nursing baby as far as systemic effects, but it can lead to diarrhea in the nursing infant because of affecting the GI flora of the bowel in the baby. So they're excreted unchanged in the urine, so they're not metabolized. So that's kind of a unique thing. You have to put that on your little chart, right? Excreted unchanged in the urine. And they've got a very short half-life, only about 2 to 3 hours. They depend on the kidney for excretion, which is, obviously they do because they're excreted in the urine and they're excreted unchanged. But one of the major side effects, major adverse effects of this is they're nephrotoxic. Okay, so meaning they're toxic to the kidney. So here you have a drug excreted by the kidney, and they're toxic to the kidney. And so these are a category of drugs that we've really spent a lot of time trying to determine, how do we keep patients from seeing this toxicity. And so not only are they toxic to the kidney, but they're also toxic to the ear. So we'll call that ototoxicity. And this ototoxicity is actually permanent. So we can have permanent hearing loss based on this. In fact, about 2 to 10% of patients experience ototoxicity, and about 6 to 10% of patients on these drugs experience nephrotoxicity. So these are very, very common adverse reactions that we see, or adverse effects that we see. So because of that, I should back up that the toxicity itself is associated with either elevated trough levels or sustained peak levels. And so let me say what I mean by that. And so if we look at the graph on the bottom right hand corner, this is a plasma concentration versus time graph. And so let's look at the blue line first. And so what I'm talking about with peaks would be the top of the blue line, right, where the peak of the blue line graph. And by troughs, that would be the bottom of the blue line. And that green area is an area that we call the washout area. That's an area that you need to get to prevent or help prevent, at least diminish the risk of these adverse events. And so the risk, and the longer that we're above that green line, the higher the risk for having these adverse events, the ototoxicity and nephrotoxicity. So this is one drug, or I should say class of drugs, that we commonly actually measure those blood levels. So we actually draw blood in these patients and look at trough levels and look at peak levels. And so that's a way that we can try to prevent that. So we want to make sure that, particularly the trough levels, make sure we're getting down below that green line. If we're not getting down that far, then we're going to have to redose or redose that person, and I should say dose that person less, right? So decrease the dose on that. The other way with that is becoming more common with aminoglycosides is to do, instead of 3 time a day dosing like we saw up there, is once a day dosing. And what we found is once a day dosing is just as effective as 3 times a day, and we have fewer adverse effects. And so if we look at the red line on the graph, this would be a single dose. So we're getting the same amount per day, 4.5 kilograms, but we're giving it at one time rather than 3 doses of 1.5 milligrams per kilogram. So we're getting the same, daily milligram dose, but it's not split up into 3 different things. And so if we see this, what happens is we get this super high peak, and then but we're in the washout area for many, many, many hours, much longer than we would be with the 3 time a day dosing. And so we found that actually decreases the amount, or I should say the risk of having these adverse effects of ototoxicity, nephrotoxicity. Interestingly enough, we also have what's called the post-antibiotic effect. So even though that drug is really, really low in concentration for that period of time, it's still killing bacteria. And we're not really sure the mechanism, at least I'm not familiar with the mechanism, at least at this point, why that works, but we know that it actually does, so it works just as well. So some of the factors that are associated with nephrotoxicity would be duration of treatment. So the longer the patient's being treated, the higher the risk of nephrotoxicity. Older people are at higher risk. People with compromised renal function, so renal disease type people would be at a higher risk. Volume depletion, so in other words, dehydration would put a patient at a higher risk for this. And as we spoke already, elevated peak and trough levels put you at risk. And then a couple of other drugs like non-steroidal anti-inflammatory drugs, some loop diuretics, which we'll cover in the diuretic lectures, and vancomycin, which we're not going to cover in this class, but it's a drug that is also used against gram-negative bacteria like Pseudomonas when aminoglycosides are indicated. Ototoxicity is also, if you're using loop diuretics, you also have a higher risk of ototoxicity from concurrent because they're also ototoxic. So if you're using loop diuretics along with aminoglycosides, you run a higher risk of ear problems. Fluoroquinolone antibiotics are actually a relatively new class. It's a class that's come out since I have been in practice. So I believe, if I remember right, they came out in the late 80s, and they were just a miracle drug. I mean, they were it was kind of fun to experience as a practitioner. A new antibiotic, because there just is very little resistance out there at that point. And even today, there's not a lot of resistance that we see out in the bacteria world to these particular antibiotics. The two brands the two drugs I want you to be familiar with are ciprofloxacin and norfloxacin. Cipro is the brand name for ciprofloxacin. Norfloxacin is Noroxen. They're actually called fluoroquinolones, again, because of their structure, much like we said with beta-lactam antibiotics. So if we look at that down in the bottom right-hand corner, looking at the structure of these drugs, of these antibiotics, that the blue rings are the quinolone rings, and notice that they've got a fluorine that are off of them, and so that's where they came up with that term fluoroquinolone. So these typically are used to treat susceptible strains of gram-negative bacteria, but there is some gram-positive activity in them as well. So they're very, very effective drugs for urinary tract infections, respiratory tract infections, skin infections, and so they've got a lot of activity in different areas of the body. So they work by interfering with DNA replication, so totally different than the drugs that we've looked at up to this point in time. The antibiotics that we looked up to at this point in time. And again, it works in both susceptible gram-negative bacteria, but also gram-positive, which I don't have in that list. And they really prevent cell reproduction because they're inhibiting that DNA replication. The way they work is they inhibit a couple of enzymes. The first being DNA gyrase, which is the enzyme that's inhibited in the gram-negative bacteria. DNA gyrase is an enzyme that forms a supercoil required for the replication of the DNA in the bacteria. And so if you don't get that supercoil formation, then replication just stops at that point. In gram-positive bacteria, they inhibit the topoisomerase 4 enzyme. And topoisomerase actually separates the daughter DNA strand from the original strand, so we can't get that separation, and so therefore the DNA replication doesn't take place uh, in those particular bacteria. The interesting thing is they're selectively toxic to the bacteria because they do not affect the human gyrase, DNA gyrase, or topoisomerase enzymes, and so again they select for the bacteria one rather than ours. And since they make really abnormal DNA, they're bactericidal, right? So the cells actually die from the effects of fluoroquinolone antibiotics. Pharmacokinetics, these are absorbed very well from the GI tract. They're like most other drugs, metabolized in the liver, and these are excreted in both the urine and the feces. So both of those routes of excretion are important in these particular antibiotics. So there's some contraindications for these. It's really our first contraindication, if you would, besides allergies. Well, actually, known allergy, right? It's contraindication. As I said, all of those. Anytime you have an allergy, that would be a contraindication. But this is actually contraindicated in pregnant women or lactating women, and the reason for that is that it affects cartilage in growing babies, growing children. And so if we actually start, all of our bones start as cartilage, and if you don't get that cartilage formation properly, then we have problems in developing as a fetus. And the same thing with lactating women. If babies are getting on their breast milk, the growth plates of the bones are cartilage, and so we don't get normal growth in the babies with that. So again, any children under 18 years, well, really any child that has growing bones should not be on fluoroquinolone antibiotics. Fluoroquinolones are pretty well tolerated. There aren't a whole lot of side effects for them, although some people will get headache, dizziness, or really some CNS effects from that. Some people complain of GI upset, which is very common with a lot of antibiotics. And some patients will have bone marrow depression, although it's not very common. Again, you can have leukopenia, thrombocytopenia, those types of things with it. Since they infect connective tissue, we have a risk of tendon rupture, but again, that's not very common. And it can make myasthenia gravis worse, which, if you remember, was an autoimmune disease that attacks the nicotinic receptors on skeletal muscles. So again, not a very common thing. So really, generally well tolerated. All those other things are pretty rare, not really all that important, unless somebody's obviously having those adverse effects. There are some drug-drug interactions with antacids and other cationic compounds. We'll see a decrease in absorption if they're used together. Quinidine, which we'll learn about quinidine, is actually a cardiac drug, an antiarrhythmic drug, and other drugs that are going to increase the QT interval. So we can have some fatal cardiac reactions. I guess that's the important part, right? Fatal cardiac reactions if we're using it with some antiarrhythmic drugs or other drugs that increase the QT interval on the ECG. And then theophylline and warfarin, it'll increase blood levels of both of those. So we want to monitor the blood concentrations of theophylline. Theophylline is an asthma medication, which is not used as commonly today as it was 20 years ago, and it has some central nervous system toxicity to it. And warfarin, we'll cover that we have covered that in our anti-clotting agents. And so obviously we'd want to check the pro time or the INR on patients that are on warfarin. Sulfa drugs, as stated previously, have been around since the 1930s, so they were one of the older categories of drugs, and specifically we call them sulfonamides. Most of the time they're used in combination with trimethoprim, which we'll learn about the mechanism in a second as to why they do this. But so these drugs actually inhibit folic acid synthesis. And they do that by inhibiting the conversion of paraminobenzoic acid, which is PABA, into folic acid. Now, bacteria, some organisms, I should say, not all, but some microorganisms that need to synthesize folic acid would be sensitive to these drugs, and we do not synthesize our folate. We get that from the diet, and so again, the inhibition of this enzyme, which is called dihydrooctoroate synthetase. I try to say that one 5 times fast. It's a competitive inhibitor for that, and so we as mammals don't need that, but some bacteria do. And trimethoprim actually inhibits another enzyme kind of down the pathway, and that enzyme is dihydrofolate reductase. And so if we look at the sequence of events that occur in the bottom right hand corner of this slide, so paraminobenzoic acid, PABA, is converted to dihydrofolic acid, which is not quite active yet, and then dihydrofolic acid is actually converted to tetrahydrofolate, which is the next step in the synthetic process. And so these enzymes, or dihydrofolate, is actually needed to synthesize purines and methionine and thiamidylate, so basically DNA and those kind of things. And so since we have a series of reactions and we block 2 enzymes in that reaction, the combination of the 2 drugs is much more effective than using the drugs individually. Sulfonamides and sulfonamides plus trimethoprim are bacteriostatic, so they do not actually kill the bacteria; they just stop replication in that. And they're indicated to treat sensitive gram-negative and gram-positive bacteria, so they're considered kind of a broad spectrum antibiotic because of that negative and positive spectrum that they cover. These are absorbed well from the GI tract, and they're typically given orally, although there is an IV product available as well, and they're metabolized by liver and excreted in the urine. Although used quite often and generally fairly safe to use, we do have some significant adverse reactions that we want to watch for in our patients. One would have to do with filtration of the drug in the kidney, and we can end up precipitating the drug crystals out and forming kidney stones. So if you look at the picture in the upper right hand corner, this is a picture of sulfur crystals in a patient that's on sulfamethoxazole and trimethoprim. And so if the patient is dehydrated or glomerular filtration rate is low for some reason, we can precipitate excess quantities of those crystals out into the kidney and result in stones. A very common side effect are drug allergies. In fact, it's estimated that about 3 to 6% of the general population is allergic to sulfonamides. And these can be a type 1, type 2, or type 3 reaction. And so all the way from atopic skin reactions, which we're seeing on the right-hand picture over there, or even anaphylaxis, which both of those would be our type 1 type reactions, to hemolytic anemia, which is a type 2 cytotoxic reaction, or serum sickness, which would be a type 3 hypersensitivity. So much like we saw with the penicillin drugs. And finally, there's some drug-drug interactions that are important. 2 of them, one is oral anticoagulants, the other is oral anti-diabetic agents, and it increases the effectiveness of both of those classes of drugs. So if a patient's put on warfarin, for example, we would have to adjust the dose if the patient's on sulfonamides for an extended period of time. And it also increases the effectiveness of the anti-diabetic agents, specifically the sulfonylureas, which we'll learn about in the diabetes section. But suffice it to say, sulfonylureas increase the secretion of insulin by your pancreatic beta cells, and sulfonylureas sulfonamides increase that capacity, and so we can see patients that become hypoglycemic when they take sulfa drugs and sulfonylureas. And here's the combination sulfa trimethoprim that I'd like you to know.
It goes by a brand name Bactrim, but it's sulfamethoxazole and trimethoprim. And here's a prototype summary that came from a previous textbook that we use in this course. And just to show you, they called it cotrimoxazole, but that would be a brand name. So typically they say sulfamethoxazole, trimethoprim, or Bactrim is actually the most common brand name that is seeing out in clinical practice. Tetracyclines are the next major class of antibiotics that we'll be looking at. And these are actually molecules or chemicals that were isolated or taken from common soil molds. And so the history is that, if we look at the microbial world, and there's just this battle that's going on continuously in the soil and environment, and there's only so much space, and so some of these bacteria have developed molds and bacteria have developed chemicals that kill other microorganisms just so that they can keep their little place. So there's, again, kind of a warfare going on. And so the ones we use today are semi-synthetic antibiotics based on those. In other words, the molecules were based on the structures that the molds were secreting, but the chemists have gotten a hold of them and changed them around a bit. So thus we use the term semi-synthetic. These are all broad-spectrum antibiotics, and the two that I'd like you to be familiar with are tetracycline and doxycycline. The actions of tetracyclines is very similar to aminoglycosides in that they inhibit protein synthesis, thus preventing cell replication, and they act in the same place, actually, on the 30S, or the small subunit of the bacterial ribosome. However, there's a major difference in that tetracyclines are not cidal like aminoglycosides. Tetracyclines are bacteriostatic. So again, that's even though they act in the same fashion, they're very different in their activity and in cell death in the bacteria. These are used for a broad range of infections, and so very commonly we use it for skin infections. It concentrates in the skin very well, and if you have people that have, for example, a penicillin allergies, this would be a very good drug or a good class of drug, I should say, to treat those individuals with for that. So pharmacokinetics is that most of these are given orally in the GI tract. In fact, we really don't have a very good injectable form of these particular drugs, so they're primarily used orally. They're concentrated in the liver and excreted unchanged in the urine and feces. So again, it's different. That's not metabolized in the liver. These are excreted unchanged in both through the bile and through the urine. Even though these are very commonly used, much like the sulfa drugs, we have a lot of issues or problems or things that we need to be aware of as we put patients on these antibiotics. First and foremost, they're contraindicated. In other words, you shouldn't give it to women who are pregnant or women who are lactating. And the primary reason for this is penicillin actually binds to calcium. And so it actually would affect development of the bones in the fetus and can discolor teeth. And so if you look at the picture on the right-hand side, here's an individual whose mother was actually on tetracyclines when her teeth developed. So you have that staining look to the teeth. They also have a lot of adverse effects, three of which we'll kind of focus on here. GI irritation is the biggest one. Very, very commonly, a common complaint of individuals that they take this and it upsets their stomach. And so a lot of people like to take this with food to try to prevent that from happening. But if you look down in the bottom, we have a drug-food interaction. So really any of the metal ions, so these positively charged ions like calcium and iron and magnesium, aluminum and zinc, will bind to the tetracycline and not allow it to be absorbed into the bloodstream. And so it's very common for people to take a glass, take the medicine with a glass of milk, the ones to prevent that GI upset. But that's just not going to be what you want to have in this particular case. So be sure they take it with water and with foods that are low in cations. So we talked about the damage to bones and teeth, so it can be incorporated into bone and teeth in pregnant women, well, I should say the babies of pregnant women. And then another very important one is what we call photosensitivity. And so there's a picture on the right-hand side. It basically is a super severe sunburn that individual can get when they're on tetracyclines. And so be sure to warn patients that it's not a great antibiotic if you're going to spend the week on a beach, basically. So finally, there's a drug-to-drug interaction, and it's there's argument as to how important this is, but we classically teach it that if you give penicillin along with tetracycline, you neutralize the effects of really both of those, and specifically penicillin. Penicillin needs actively multiplying cells to have its major activity, and tetracyclines are static, and so therefore they would stop that active multiplication and inhibit the effectiveness of penicillin G. And furthermore, it induces the cytochrome enzymes in the liver, and so you're going to get increased metabolism of drugs, and it can be an issue with things like oral contraceptives, where you're expecting, trying to prevent pregnancy, and other drugs like digoxin, which can be very toxic, and we'll talk about that in the heart unit. So again, just realize that it affects a lot of drugs because of its induction of the cytochrome P450 enzymes in the liver. The final class of antibiotics that we will be covering in this class are the macrolide antibiotics. And just like the tetracyclines, they were originally isolated from soil organisms, and they were named because of their chemistry, which we've seen very commonly in this class of antibiotics, or at least in antibiotics itself. And so if you look at the structures up top, they're named after that huge macrocyclic lactone ring. Thus they call them macrolide antibiotics. The three that are commonly prescribed today are azithromycin, or Zithromax is the brand name, clindamycin, which Cleocin is the brand name, and erythromycin, which has been generic for so long. There's multiple branded generics out there, but we won't talk about the multiple brand names that erythromycin goes by. These also inhibit protein synthesis, but in a different mechanism. They go after the big ribosomal subunit, the 50S ribosomal unit, and this is a unique class in that they could be bactericidal or bacteriostatic depending on the dose and sensitivity of the bacterial species. So we can't make any hard fast rules as to whether it's a cidal or static antibiotic. We use these in obviously susceptible bacteria like all other antibiotics, and very commonly used for Mycoplasma pneumonia, used in Legionnaire's disease, chlamydia infections, whooping cough, so the pertussis organism, pelvic inflammatory disease, and we can also use it for acne, just like the tetracyclines. Clindamycin has a little different use than we see with erythromycin and azithromycin, and that's that it's used for anaerobic bacteria primarily. So we'll use it for dental procedures, for example, where we have some anaerobes. We can use it for certain bacteria like Bacteroides fragilis, or B. frag as it goes by short term. It can also be used for Clostridium perfringens, which is a bacteria found in the GI tract and the colon in particular, and Fusobacterium and other anaerobic streps, basically. So clindamycin, when you think of clindamycin, think of anaerobic bacteria, and that's what it's primarily used for. The pharmacokinetics of macrolides, again, these are primarily used orally. We don't have injectable forms of these drugs. And it's concentrated in the liver and excreted in the bile in the active form, which means we have a fairly high concentration in erythromycin in the GI tract, moving downstream from where the bile enters the duodenum. The other ones are metabolized in the liver, and they're also excreted in the bile. So contraindications for this drug, obviously the allergies we talked about, and there is cross-sensitivity between these drugs. So if you're allergic to erythromycin, it's very likely that you're going to be allergic to clindamycin or azithromycin as well. So one allergy leads to multiple allergies, basically. Because the liver is so important for getting rid of this particular drug, we don't typically use it in patients that have liver disease or hepatic disease. And there are some significant adverse reactions. Again, most of these are GI because the drug is being excreted via the GI tract through the liver, or through the liver and into the GI tract, I should say. So very commonly you'll see people complaining about diarrhea, vomiting, cramping. So those GI effects that we see from the antibiotic killing off the bacteria that are located in the gut. And in fact, there's a really, really super important one with clindamycin, and it's when you get an overgrowth of of a bacteria called Clostridium difficile. And so essentially what's happening is clindamycin is killing a lot of the normal GI flora, and it allows Clostridium difficile to start overgrowing in that area, and it's a very toxic. It excretes a very toxic exotoxin, and it results in a disease called pseudomembranous colitis, which is a very severe form of colitis and a severe diarrhea that these patients get. And so if you look at the pictures on the right-hand side, there's a histology section of an individual that was suffering from pseudomembranous colitis. You can see the mucosal membrane down below, and then that big membrane that's up above or superficial to on the lumen side of that mucosal membrane. And so that's the pseudomembrane that is occurring, and there's a picture of it underneath what it looks like with a colonoscopy. And so that treatment for that is very, very difficult, and believe it or not, one of the more successful treatments that is gaining momentum is a fecal transfer. So you are actually taking feces from an individual and recolonizing your intestinal tract. Obviously, you're not eating it; they put it into you via an NG tube. So, but again, you're putting the normal bacteria, which now you get the dynamics back, and you won't have this overgrowth of the Clostridium difficile. Both erythromycin and azithromycin are drugs that cause prolongation of the QT interval, and so again, we have to watch for cardiac effects, and we'll talk about that more when we get to the cardiac section of this course. Macrolides are huge hepatic enzyme downregulators. So in other words, unlike tetracyclines, which we said actually increase the amount of liver metabolism that goes on, these drugs are very potent inhibitors of the enzymes of the liver. And so they interact with a lot of drugs because of that. And so we'll see increased toxicity in many drugs. And so, for example, we've talked about digoxin, our anticoagulants, so now all of a sudden we start having bleeding episodes. Theophylline, the asthma medication that has central nervous system toxicity, so we start seeing that. The same with carbamazepine. That's an epileptic drug, which causes suppression of the brain, and then also our corticosteroids. So we'll start having higher concentrations of our glucocorticoids because of that. So these are actually the animal models for studying downregulation of enzymes are actually injecting erythromycin into those animals, or giving those animals, I should say, erythromycin to downregulate them. Much like tetracycline, there's a food-drug interaction. And so really, these macrolides, that big old macrocyclic lactone ring binds to the food and doesn't allow absorption because of that. So it really sticks there and just kind of passes on through the feces. And so it's recommended to take these on an empty stomach. obviously we want to minimize the GI effects as much as we can, and so and these do upset people's stomachs, right? We talked about that already, the GI effect, and so some people just can't tolerate taking macrolide antibiotics because of how it upsets their stomach and the fact that they can't take it with food to try to alleviate that from occurring. So to summarize, we kind of walked through all those antibiotics, and I think maybe now you can see the wisdom as to why we need to make drug charts, because there's a lot of information to try to keep track of between each antibiotic class, in addition to the individual antibiotics within that class. And so this is a nice summary slide, and really, before you leave here, we didn't cover all these drugs in this class, but you should really be familiar with basically all of them on this list, and there's some more here that you're going to need to learn about that aren't even on this list. But so just quick looking at it again, we have drugs that interact with cell wall synthesis and cell wall integrity, and so those would be, we covered the penicillins and cephalosporins, and we also have vancomycin in that group, which is a very important one that you'll learn about later on in your nursing education. We have those that affect the DNA synthesis, DNA gyrase for the quinolones. Metronidazole is another one that you'll learn about later on. That's a very important one that we didn't cover in this class. We have those that affect the phospholipid membranes, and so we unfortunately didn't cover that. Those are the polymyxins like amphotericin. We talked about the antifungals that actually poke holes into the membrane. Again, that's something you'll learn down the road. We have antibiotics that affect protein synthesis. So we have the macrolides that are 50S inhibitors of the ribosome. So erythromycin, clindamycin. There's some others that are on this list. Azithromycin is a newer one. Chloramphenicol, lincomycin you don't see used in humans very often anymore, but again that'd be another macrolide antibiotic that I didn't put on your list. And then you've got the 30S ribosome inhibitors for protein synthesis, and so we looked at our tetracycline and our aminoglycosides like streptomycin, gentamicin, those type of drugs that are 30S ribosome inhibitors. So let's finish our lecture video, I guess, with a few questions. And what I'll do is maybe I'll read the question, then I'll wait 10 seconds, and if you want to hit the pause button, that would work fine as well, and to give you time to read and think about this question. But so you're a nurse caring for a patient receiving intravenous gentamicin for severe bacterial infection. Which assessment finding by the nurse indicates that the patient has experienced an adverse effect in gentamicin therapy? So if you said D, you would be correct, tinnitus, because gentamicin, if you remember, has ototoxicity, so we have accumulation of the drug in the inner ear, and so tinnitus or headache or dizziness would be things that we'd want to look for in that nurse. And if we remember other major adverse effects of aminoglycoside antibiotics like gentamicin would be nephrotoxicity. All right, the next question is, a patient with a history of severe anaphylactic reactions to penicillin has an order to receive cephalosporin. What should you as a nurse do? So if you answered B, contact the healthcare provider for a different antibiotic, you would be correct. If you remember, I was taught that there was a 10% cross-reactivity with allergies, where really it's about 1% at this point, but it's high enough that it's something that we should be concerned about. So if at all possible, patients with penicillin allergy should not be treated with any member of the penicillin family unless it's really truly necessary. And so you remember that the use of cephalosporin depends on the intensity of the allergic response to penicillin. So if the penicillin allergy is mild, it's probably safe to use cephalosporins. However, if the allergy is severe, for example, an anaphylactic reaction or something of that nature, or an arthritis reaction, or even serum sickness, cephalosporin should probably be avoided. So the final question will be: a patient is prescribed doxycycline. If the patient complains of gastric irritation, what should the nurse do? So if you answered C, give the patient food such as crackers or toast with the medication, you would be correct. You certainly wouldn't want to do A, instruct the patient to take this medication with milk, because if you remember, tetracycline forms an insoluble chelate with calcium, iron, magnesium, aluminum, zinc, and that'll decrease the absorption. So tetracycline should not be administered together with milk or antacids. Long-acting tetracycline, such as doxycycline, may be taken with food, and food does not affect the absorption unless it's a high calcium food, something like yogurt or cottage cheese or milk, those types of things. So that is our survey of the antibiotics that we deem important. And I always end this lecture, it's kind of funny, with a question as to what cranial nerve is affecting this giraffe. So this giraffe actually has something going on that people get as well. And so we can probably discuss this when we meet as a class again. So maybe I'll give you a challenge as a homework assignment to find out which cranial nerve is causing that funny looking face that we see on this giraffe. But back to being serious, again, I highly encourage you to get your charts made together. Bring questions to class. We'll review some of this material. If you have any questions for me when we meet next, I would be happy to answer them for you.